A very warm good evening and namaste to all. I am Dr. Abhishek, Manager Scientific Services from Himalaya Wellness Company. It is indeed a moment of immense pleasure to welcome all the doctors who are on board. On the behalf of Himalaya Wellness Company, I extend my earnest greetings and regards to our eminent guest speaker, Dr. Abhishek Jain sir, and those who have logged in today. Though virtually, let us all come together to light the lamp to keep the flame of wellness and happiness alive. Thank you so much. Doctors, as you all know, this has been our vision since 1930 of bringing in a wellness in every home, happiness in every heart. And we are associated, because of your constant support and patronage, we have completed successful 91 years of your trust and service in this field. We have been in constant touch with all of you with various means. Now, this is another our modest attempt to organize this online event on the occasion of World Kidney Day with our eminent guest speaker, Dr. Abhishek Jain sir. As you all know, doctors, that World Kidney Day is observed on 10th of March every year. This year, World Kidney Day Steering Committee has declared to be the year of kidney health for all. This campaign will specifically focus on increasing awareness and education about kidney health or renal diseases. So before coming to the session, doctors, we have a small surprise for all of you. This is nothing but some poll questions. Each and everyone can participate in these poll questions. There will be no right or wrong answers. It is just a poll question. And everybody will get around 10 seconds to participate. Now I request Mr. Nishad to make poll questions live.
Yes.
Yeah, thank you, Mr. Nishad. First question, please. As per you, what percentage of kidney stone patients end up with renal complication? Less than 5%, 5 to 10%, greater than 10%, or greater than more than 20%. Doctors, you will have 10 seconds to participate. Can we have results, Mr. Nishad? Mr. Nishad, can we have results, please?
Sir, give me 10 seconds, please.
Yeah.
Sir, there seems to be some technical difficulty.
Yeah. Okay.
Give me 5 more seconds. Let me check.
Yeah. So can we take up results in the end, Mr. Nishad? We can take next poll question.
Yes, sir, you can do that too.
Yeah. So second question, please. A second one. Yeah. So here comes the second poll question, doctors, for all of you. As per you, what size of kidney stone can be medically managed? Only less than 5 mm, 5 to 10 mm, more than 12 mm, or none of the above. You have 10 seconds, doctors. There are no wrong or right answers. Now can we have results, Mr. Nishad? Yeah. Again, I think some technical glitch is there. We can have third poll question, Mr. Nishad.
Sir, can we please do the first question again? And then
Yeah, sure.
Okay.
Yeah. Once again, doctors, sorry for this technical glitch that we are having. First question, as per you, what percentage of kidney stone patients end up with renal complication? Less than 5%, 5 to 10%, more than 10%, and option D, more than 20%. Can we have results?
Yes, sir, 2 seconds.
Yeah. If it still persists, Mr. Nishant, we can have in the end. So here are the results, doctors. 100% of you suggested for 5 to 10%. Now, coming to the second question. As per you, what size of kidney stone can be medically managed? A, only less than 5 mm, B, 5 to 10 mm, more than 12 mm, and none of the above. Doctors, you have 10 seconds to participate. Can we have results, Mr. Nishad? Yes. So as per you, doctors, 5 to 10 mm, 75% doctors agrees on it, and more than 12 mm, 25% doctors agrees on it. Can we have a third poll question, Mr. Nishad? What are the common complications you have come across while managing kidney stone? So first one is infection, second kidney injury, third bleeding, and D, option D for all. You have 10 seconds, doctors. Can we have results, Mr. Nishad? Yeah, thank you. So 22% doctors suggest go for infection, 22% renal injury, 0% for bleeding, and all for 56%. So thank you so much, doctors, for participating in this poll questions. Yes. Now, it's my honor and privilege to introduce our eminent guest speaker, Dr. Abhishek Jain sir. He is MBBS, MS, MCH Urology, and Senior Consultant, Vardhaman Hospital, Meerut. Dr. Abhishek Jain sir has completed his MBBS from MLB Medical College, Jhansi, MS in General Surgery from LLRM Medical College, Meerut, and MCH Urology from CSMM University, erstwhile KGMC, Lucknow. Currently, he is Senior Consultant Urologist at Vardhaman Hospital, Meerut. During his academic career, he has received many awards and medals like Dr. Sitaram Kapoor Gold Medal for securing highest marks in physiology, Dr. K.C. Barthwal Gold Medal for securing highest marks in first professional, Dr. B.G. Prasad Gold Medal for securing highest mark in SPM, and so on. At the same time, he has also published various research papers in national and international journals. These are the few which he has published in Indian Journal of Urology. At the same time, he's also he was junior resident at LLRM Medical College, Meerut. After his MS in general surgery, he served as senior resident at LLRM Medical College, Meerut, and also he served as assistant professor, general surgery in LLRM Medical College, Meerut. So, thank you so much, Abhishek Jain sir, for joining us today for this talk on the occasion of World Kidney Day. I request all the doctors stay tuned, and over to you, sir, Abhishek Jain sir.
Thank you, Dr. Abhishek.
Thank you, sir. You are audible, sir.
Okay. Good evening, everybody, senior and juniors, and my colleagues. Today topic, as you know, complication during the management of the kidney stone. First, I want to congratulate on the World Kidney Day, as Dr. Abhishek told. It is celebrated every second Thursday of the March. This year, it was celebrated on the 10th of March, and this year theme is the kidney health for all. As we are more aware of our health of cardiac and brain health, but nobody is aware of our kidney. So, World Kidney Society want to aware everybody for kidney health also, because kidney is as important as heart, as brain. As you know, we have two kidneys, ureter, one bladder, urethra. Main urinary system is made of the kidney. This is the picture of the right kidney.
Sorry to interrupt you, sir. Your screen is not visible. Your screen is not visible. Yeah.
I again. 1 minute. Share screen. This time visible?
Yes, sir, it is.
Okay. Now it is visible?
Sir, it is visible, but it is not coming up properly. You can share again. Just cancel it and share again, sir. प्रेजेंटेशन मोड में कीजिए सर.
I am starting to present. Yes, now it is okay.
No, sir. Again, same thing is happening. Earlier you did it. Yeah.
Dear sir, kindly come out of the presentation mode and after sharing the screen and start the slideshow again.
Okay.
Yes, sir. Yeah.
Yes. 1 minute. Now it is better.
Sir, same thing is happening, sir. Just unshare it and share it again and make it in presentation mode. You did it earlier also, sir.
Okay, share screen. This one. This one. This one. What about this time?
Same thing
problem.
is happening, sir.
Okay. So what
Yeah,
to do?
Sir, kindly stop the presentation. Please press escape.
Okay.
And
Escape.
and sir,
Now share.
share screen. Share screen again.
तो दोबारा से एक बार बंद करके देखते हैं. मैं दोबारा से ज्वाइन करता हूँ.
Is it coming, sir?
Yes, I am starting again with this name.
The screen is not visible, sir. Kindly share the screen.
Visible, sir.
1 minute. Thanks. What you are saying now?
सर एक बार स्टॉप शेयरिंग कीजिए, उसके बाद you can share
नहीं,
again.
अभी क्या आ रहा है आपकी
Nishad,
screen
you are
पर?
there?
Nothing is
No, sir.
visible.
Yes, sir. Sir, I'll instruct you. Please follow them.
Okay.
Sir, just open
1
your.
minute, Nishad, 1 minute. This is इसमें लगा दो चार्ज। क्या कह रहे हैं बताएं।
सर पहले तो आप पीपीटी ओपन कीजिए साइड में।
कर दिए ओपन, ठीक है।
उसको स्लाइड शो मोड में डालिए।
डाल दिया मैंने स्लाइड शो।
ओके सर। सर अभी ऑल्ट टैब करके जूम में आइए। ऑल्ट एंड टैब।
ऑल्ट एंड टैब, यस। एक यस,
सर जूम में
आ
आ
गया।
सर अभी इधर
हाँ।
शेयर स्क्रीन पे क्लिक कीजिए और जो उसमें 2 ऑप्शंस दिखेगा, उसमें से जो फुल स्क्रीन है
एक
पीपीटी।
सेकंड।
ओके सर।
ये ऑल्ट और टैब करके मैं जूम पे आ गया।
ओके सर। सर इसमें अभी आपको
नहीं
शेयर
आया,
स्क्रीन।
नहीं आया, नहीं।
सर
ये
ऑल्ट
आ गया।
टैब 2 बार होगा शायद, जहाँ पे भी होगा वहाँ पे आपको छोड़ना पड़ेगा टैब।
हाँ वही।
फिर आप क्लिक भी कर सकते हैं। जब भी ऑल्ट टैब करेंगे उसके बाद
क्या चीज?
क्लिक कर लीजिए जूम पे।
एक सेकंड, लीव करना पड़ेगा इसको ना। अभी तो जब ट्रायल कर रहे थे हम लोग, जब तो ठीक चल रहा था ये। अब क्या प्रॉब्लम आ रही है?
सर जूम का इशू है सर।
हाँ, जूम का इशू आ रहा है।
Can you start again, sir, in the same way?
Sir,
Yes.
it's okay, sir. You can just start your Zoom normally, and then आप सिर्फ Zoom स्टार्ट कीजिए, वहाँ पे से शेयर स्क्रीन करके आप पीपीटी।
मैंने दोबारा से शुरू किया, देखें आप इसको।
प्रेजेंटेशन मोड कीजिए सर।
हाँ। What about this time?
Sir, press escape once more. It's not showing. Please
Yes.
press escape once more. And sir, F5 दबाइए।
क्या दबाना है?
F5.
F5, yes. Constant 5, yes.
सर आप एस्केप कर लीजिए और वी कैन हैव लाइक दैट ओनली। आप स्लाइड वैसे ही जो आप आगे बढ़ते
सर
रहिए।
विदाउट स्लाइड शो मोड में ही चलेगा।
विदाउट स्लाइड शो वी कैन डू सर, बिकॉज इट इज सम टेक्निकल ग्लिच सर।
या फिर सर आपका स्लाइड शो के बगल में एक बुक जैसा आइकन दिख रहा है, रीडिंग मोड, आप उस पे कर लीजिए।
मैम इट्स फाइन मैम, लेट्स कंटिन्यू लाइक दिस। आई विल एडिट इट।
Yes, it is coming now. Yes, it is coming.
Coming?
Yes, sir, it is coming, sir. You can proceed, sir.
Okay.
Yeah.
Okay. Good. ठीक है. Now it is better.
Yes, sir, it is coming nicely, sir.
Okay.
Yeah.
Thank you. ठीक है. Now come to the definition. As we all know, the nephrolithiasis means a stone in the kidney system. It is also termed as urolithiasis. When the difference between nephro and urolithiasis, nephrolithiasis stands for the kidney stone, while the urolithiasis stands for kidney, ureteric bladder, or the urethral stone. Renal calculi and renal stone is also named for the urolithiasis or the nephrolithiasis. Stone is the accumulation of hard, solid, non-metallic mineral in the urinary tract. And the stone pain is to be said the worst type of pain after the labor pain. Now come to the few word about the epidemiology of the renal stone. Renal stone are more common in the man than the woman because there is some thought that estrogen helpful in the prevention of stone formation, while and other men are more labor class and more work in the out environment than the female. But nowadays the gender gap is start narrowing. There is a difference between the races. White having the highest incidence of upper tract stone compared with the Asian, Hispanic, and the African American. Prevalence of stone disease shows geographic variability all over the world and same in the country. As we live in the UP, Madhya Pradesh, and other things, they have the more chances of stone formation than the southern India part because due to the presence of the climate and water variability. The risk of the stone disease also correlated to the weight and the BMI. It is seen that obese person are more prone to the stone disease than the lean and thin person. Stone disease also correlated with the many metabolic disease like metabolic syndrome, diabetes, and the cardiovascular disease. One interesting thing I want to share that in a study, so if a patient of young patient with stone disease having the high chances of around 31% more chances of MI than the non-stone formers. The lifetime risk of kidney stone is approximately 13% for men and the 17% for the female. Among the kidney stone, approximately 80% consist of mainly calcium oxalate or phosphate or mixture of the calcium oxalate and phosphate. For formation of kidney stone occur where there is supersaturation of these crystal forming substance like the calcium oxalate or the uric acid high in the kidney. And same, the inhibitor of the urinary concentration of these substances are low. These urinary inhibitors are citrate, trans-phosphate protein, and the neprocalcium, all present in the during the urine formation in the kidney. Now, some risk factor for the kidney stone. As I told you earlier, the environmental risk factor like hot, arid climate, low fluid intake, low calcium intake, and the high sulfur intake lead to the formation of the kidney stone. There is a mixed type of evidence available for role of increased animal protein, high sodium intake, high sucrose intake, or the low magnesium intake. Risk of kidney stone also increased by medical conditions as the obesity, diabetes mellitus, primary hyperparathyroidism that lead to the increase in the parathyroid hormone that lead to the hypercalcemia and the hypercalciuria. Gout, in this gout, as we know, there is high chances of hyperuricemia and the hyperuricemia. And anatomic abnormality of the kidney like the UPJ obstruction, urinary any obstruction, lead to the formation of spaces and lead to the formation of the kidney stone. Genetic factor also thought to account for about half of the risk of developing stone in the form of obesity, diabetes, and other things lead to the kidney stone formation. Now, few word about the recurrence of the kidney stone. As it is quite common in the general public कि एक बार operation कराने के बाद दोबारा पथरी तो नहीं बनेगी. It is seen that following an initial stone event, the 5-year recurrence rate in the absence of specific treatment is 35 to 50%. Means within 5 years, 50% of patients को stone बनने के दोबारा chances हैं. And recurrence can be diagnosed by radiographic. Means to patient एक्सरे अल्ट्रासाउंड किसी और चीज के लिए कराने के और पता चला कि उसको किडनी में स्टोन है. और सिम्टोमेटिक रिकरेंस, patient is complaining of pain like the stone and he knows the radiography of the stone. Kidney stone recurrence increases the risk of developing chronic kidney disease. Kidney stone is a common cause of chronic kidney disease. It is seen around 5 to 10% of patients of stone land up into the CKD. Stone composition and the relative occurrence. As I told you earlier, the calcium oxalate or calcium phosphate is the most common type of stone and makes around 80% of the total amount. Rest is the uric acid, 7%. Struvite is calcium, magnesium, phosphate, 7%. Cystine, is silica and hydroxyoadenine, less than 1%. These are the drug-related stone. Now, clinical manifestation, as you all know, The most common clinical symptom is the severe abdominal or the flank pain that is radiating to low and to groin with urinary frequency, difficulty in micturition, burning micturition. Sometimes in the solitary kidney or the bilateral stone disease, patient present with the oliguria and alluria, and few patients complaining of hematuria. When the stone causes the obstruction and later on fever with present with the fever and septicemia. Sometimes we see patient complaining of only fever, and when we investigate the patient, we see the patient having pyelonephritis and having pyonephrosis, the cause of fever. As we all know, the kidney is innervated by the sympathetic and the parasympathetic. There is no peripheral nervous system in the kidney. So obstruction due to dilatation of lead to the dilatation of spacing of the upper ureter and the renal pelvis. That is lead to the sparse, severe abdominal pain and dysuria. This present with the acute loin to groin, colicky pain associated with nausea and vomiting. And this stands for the renal angle tenderness and the microscopic hematuria. Now, 50% or more we can diagnose by the history and the clinical examination. But patients like oliguria, injuria, fever with septicemia, the clinical picture is not as pain disease. So investigation is advised, like biochemical examination in this first and foremost is the kidney function test, urine routine microscopic culture, uric acid, blood sugar level, and the CBC. In the radiological, commonly advised ultrasonography, X-ray cube, and when the diagnosis is confirmed, then specific non-contrast CT cube, CT urography, IVP, or the MRI depend on the patient condition and requirement. The first and foremost is the ultrasonography, either ultrasound whole abdomen or the ultrasound AUB is advised. It is widely available and it is quite cheap in our India, and there is no chances of radiation, so safe in the pregnancy also. But the limitation with the UD is it is poor sensitivity, but having a good specificity. Its sensitivity is only 61%, while specificity is the 97%. Sensitivity is good in the kidney, but poor in the ureteric. It is failed most of the time, the mid-ureteric and the lower ureteric parts. As you show, it is the stone in the renal pelvis and it is associated hydronephrosis in the kidney. Same thing in this stone at the fusion, and this is the posterior acoustic shadow formed by the stone in the UST. X-ray KUB, as we all know, it is the oldest method to know the stone. It is poor sensitivity and specificity. Sensitivity is around 57% and the specificity is the 76%. Specificity is poor due to the presence of lip, calcified lymph node, or sometimes bony spike or the bony mass that mimic with the stone. So limitation is unable to show the radiofluorescent. It is old dictum. Most of the stone are radio opaque in the renal, and most of the gallstone are the radiolucent. The dictum is 10% of renal stone are radiolucent and 10% of gallstone are the radio opaque. And the other is the overlying structure interfere detection. You X-ray of the stone. It is type of staghorn stone, and it is a upper ureteric stone. To improve the diagnosis, IVP or IVU is performed. IVP means intravenous pyelography or intravenous urography. It gives the information of renal anatomy and function and increase the specificity specifically in the 95% and the sensitivity is the 70%. But the limitation need of IV contrast, and sometimes IV contrast is allergic to the patient and can cause anaphylaxis reaction. and it cannot be performed if patient kidney function is not normal. And other limitation of IVP is that it can give only information around the KU, but can't give other information regarding the other causes. Few picture of IVP. It is bilateral normal functioning kidney with the bilateral normal ureter and the bladder. While the other picture normally functioning left kidney, but the right kidney is not visualized with the upper ureter. So diagnosis in this case is poorly functioning or the non-functioning kidney with the upper ureteric stone. NCCT or the non-contrast CT is the gold standard to detect the renal and the ureteric stone. It is high sensitivity and the specificity around 97 and 98. Its advantage is diagnostic accuracy and give the rapid result within 5 to 10 minutes. The picture shows there is a renal beauty or the renal pelvic stone. But the disadvantage is it is expensive, high radiation exposure, and you will surprise it is also not 100% visualized stone. The time of stone like drug stone, indinavir stone are not visualized even in the NCCT. CT urography, when we give the contrast and take the picture of renal pelvic calyceal and the system, it is called a CT urography. In addition to non-contact, it helps to see the function, rule out obstruction, and inflammatory changes in the renal system. It is the image of a CT urography, right kidney ureter, by left showing the bifid system, complete bifid system. It is upper moiety, it is the lower moiety. MRI having the limited useful in the diagnosis of the nephrolithiasis, as we know, calcium containing stone are more common, and the calcium containing thing are not so visualized in the MRI, but helpful in when there is contraindication of CT and patient need to diagnose even after the UIG, then like in the pregnancy, MRI is helpful because it is non-radiation. Now come to the management. Management can be divided into emergency therapy, medical therapy, and the mainstay of treatment is the surgical therapy, which can be non-invasive, minimal invasive, or the open surgery. First is the emergency management. As we know, the pain is the most common symptom. Patient is managed by NSAID. Diclofenac is either IV or IMF is the drug of choice for the pain. If it is not controlled or contraindicated due to poor renal function or other things, then offered analgesic containing of tramadol or Butrem, spasmolytic like rotavirine, dicyclomine can be given. If patient is complaining of vomiting, then antiemetic, ondansetron, pirinesetron, or perinorm like injection can be given along with PPI or the H2 blocker like ranitidine or the pantoprazole. If patient is unable to take them, IV fluid, it also helps. Medical management, as asked by
sorry to interrupt you, sir. Abhishek Jan, sir. Your voice is slightly low. Can you speak a little loudly, sir?
Okay.
Yes, thank you, sir. Because some noise is also coming.
Okay, I will increase my sound also. Medical management. It is now better.
Yes,
medical
sir.
management.
Yes, sir, it is better.
Okay. Medical management. First is the medical expulsive therapy. Helpful in the distal ureteric small stone up to 5 to 10 mm. As we discussed in the initial, expulsive therapy is helpful up to the 10 mm. Incidence, if stone is small size and there is no obstacle distal to the stone removal, up to 65% of the chances of the stone passage if the stone is small in the distal ureter. The mode of action in the medical expulsive therapy is the ureteral relaxation, and increase the hydrostatic pressure proximal to the stone. The mainstay in the medical expulsive therapy is the alpha blocker. It consists of tamsulosin, alfuzosin, or the silodosin. Most common drug of choice is the tamsulosin. Then other with unproven benefit is the steroid. Deflazacort, the dose of 6 mg GD or the 30 mg OD is also helpful. For it, the next question, you will think how many times we can wait for the expulsive therapy. If patient having no pain or no sign of complication, then we can give it up to the 14 days. If after the 14 days, if it is not progression in the stone movement, then we should start thinking about the surgical removal of the stone. Then the herbal medication like Cystone. Cystone and the Cystone food also helpful in the medical expulsive therapy. Now into the surgical management. Surgical management is the mainstay in the treatment of the kidney stone. I think it is the most important slide for the management of renal stone. That's a factor affecting in the management. First is the stone. Factor about the stone number, stone size and location, stone composition and hardness. Composition and hardness can be assumed that if the stone is more ounce-filled unit, more than 1,000 ounce-filled unit, it is hard. If it is less than 1,000 ounce-filled unit in the CT scan, it is assumed to be soft. Patient factor like obesity. Obesity is problematic both in the lithotripsy, both in the PCNS, comorbid condition like diabetes, hypertension, coronary artery disease, chronic obstructive pulmonary disease or the CRF, also problematic during anesthesia and other comorbidity. Coagulopathy, patient having low platelet count or decrease in the prothrombin time of the APT. Pregnancy, in pregnancy we can't use radiation, CAM and other things. If patient is having solitary kidney or the transplant kidney, it is also we have to care full manage this type of patient. Patient symptoms like some patient having less type of pain and less symptom, but some patient have very high pain and other things, and patient show sign of infection or the septicemia. Third is the renal anatomic factor, like patient having obstruction or stasis due to the stone, hydronephrosis, it is mild, moderate, or the severe type of hydronephrosis, uretropelvic junction obstruction, calyceal obstruction, horseshoe kidney, or the renal ectopia. So we should keep in the mind stone factor, patient factor, and the renal anatomical factor in the treatment of the kidney stone management. The first hand is the minimal invasive, or the non-invasive is the ESW, is the real shock wave lithotripsy. Shock wave are the weak non-intrusive waves that are generated externally and transmitted to the body and focused on the stone. As you see in this picture, patient put on the lithotripsy table, and so we can focus the stone through the CAM or the ultrasound, and by focusing the stone, shock wave are put, and that break up the stone, and these part of the stone pass through the urine. So shock wave build to sufficient strength only at the target where they generate enough force to fragment a stone. There are three types of shock wave generator are available. These are the electrohydraulic, electromagnetic, and the piezoelectric. First is the electrohydraulic. In the electrohydraulic, it is little cheaper than other electromagnetic and the piezoelectric, but it having the more pain than the electromagnetic and other. In this electrohydraulic, it is a electrode that produce the shock wave through focus 1 to the focus 2. Focus 2 at the stone level. And these all shock wave focus at the stone and break the stone. In the electromagnetic, there are electromagnetic coils that generate the shock wave, and with the help of acoustic lens, it focuses at the stone. Electromagnetic is the more controllable and the reproducible, and it is causes the less pain in comparison to the electro-hydraulic. It is a sturdy machine, but the main problem is the cost preference. It is more costly than the electro-hydraulic. Piezoelectric are less available in comparison to the electro-hydraulic and the electromagnetic. In this piezoelectric, unlike with the EHL and the electromagnetic, there are multiple forces that produce the shock wave and in a spherical disk, and this focus all the shock wave at the focus point at the stone. The advantage in the piezoelectric is the focusing accuracy and a long service life without pain, because there is a relatively low energy density at the skin entry point of the shock wave. But it is a costly machine even than the electromagnetic. Now, few words how the shock wave works. Shock wave works by forming a bubble, either symmetrical or the asymmetrical bubble. These asymmetrical or the symmetrical bubble work like the missiles for the stone, and that make a micro cracks like in the stone. And these micro cracks, when the urine pass through it, become the macro cracks and become the fragment of the stone. And these stone fragments go into the ureter through the bladder and pass through the urine. Other important is the PCN. PCNL stands for percutaneous nephrolithosis. It is the procedure of choice for the large kidney stone. There are miniaturization of the scope and the system. 3 types of PCNL are available. Standard PCNL, 24 to 30 French of the implant sheath are put. Mini PCNL, 14 to 20 French. Micro PCNL, 10 to 14 French of puncture is needed. Now I will show you a video of PCNL, how PCNL do. We know basically ureter, bladder, and this is the stone. Now it can be done under spinal anesthesia or the general anesthesia. First we pass a scope and then pass a ureteric catheter through the cystoscope into the kidney. With the help of this ureteric catheter, we can see the pelvic calyceal system anatomy by the RGP. RGP is the retrograde pylorography. Then we put the patient into the prone position and pass a needle under guidance of fluoroscopy and pass a guide wire into the pelvic calyceal system. On this guide wire, we dilate a tract, depend on the procedure, standard, micro, macro, PCNL. This sheath is called the implant sheath. Through this sheath, we can pass a scope called the nephroscope, and this nephroscope directly visualize the stone. If the stone is small, we can grasp it. If the stone is large, we can break it into the fragment and remove through the forceps or the stone basket. After clearance, we see into the fluoroscopy to complete clearance. If it is complete, there is no fragment, then we put a DJ stent. DJ stent is a double J stent because both of it and are J type to prevent the movement. After this, we remove the disemplasia, or sometimes we put a tube into the kidney. This is called the nephrostomy tube, and it is removed 1 or 2 days later. And DJ stent are normally removed after 2 to 3 weeks, and patient can be discharged after 1 or 2 days. Other mode of modality is the RIRS or the URS. RIRS means retrograde intrarenal surgery. In this, we use a flexible ureteroscope and having a 320 degree of movement. And through the urethra, we can put in the ureter and can see into the kidney. Other is the URS. URS stands for the semi-rigid ureteroscope. It is semi-flexible and it can go up to mid-ureter or the upper ureter and go into the kidney. It is a video of RIRS. Bladder, urethra, ureter, kidney. This is the stone. Same thing like the PCN. We put a guide wire through the cystoscope into the ureter and up to the kidney. Am I audible clearly?
Yes, sir, you are audible clearly, sir.
Okay, thank you. We put a guide wire up to the kidney. We can do RGP to see the pelvic axial system as we do the PCN. Then we put a ureteral axis sheet up to the upper ureter. It will have to put in and out for the ureteroscope. Then we put a ureteroscope and see the stone. After seeing the stone, we use laser energy to break it. After making fragment or the powder, we remove the fragment with the help of stone basket or the forceps and kept into the bladder or outside the urethra. After completing, we will see in the hole in the calyx to see for the residual fragment. When we confirm it is clear, then we will put a DJ stent as we will put in the PCN. DJ stent helpful for the passage of a small fragment or small clot and other. Then we will put the Foley's catheter for 1 day and patient can be discharged next day. DJ stent removal after 2 to 3 weeks. Now, few words about the open or the laparoscopic or the robotic surgery. As we all know, there is limited role in the current era of the open surgery because we can do large stone by the PCN and small stone by the RIRS. But I can't say if there is no need of open or the laparoscopic surgery. For kidney stone, pyelolithotomy is when we open the pelvis, and laparolithotomy when we open through the kidney. Same thing when we are doing with the laparoscopic or the robotic, it is called the robotic or the laparolithotomy or the pyelolithotomy. Now, kidney stone plan. If kidney stone is more than 20 ml, it is the treatment of choice is PCNL or the RIRS. More than 20 ml, lithotripsy having the very limited role. In 10 to 20 ml, shockwave lithotripsy or endourology means PCNL or the RIRS. While less than 10 mm, shockwave lithotripsy is the treatment of choice or the RIRS. In the small stone, PCNL is not recommended. But treatment hole in the lower hole. In the lower hole, lithotripsy, having the poor result due to the lower lithotripsy because there is stone fragment have to move lower to the upper to remove. So, if it is less than 1 centimeter and softer variety with the skin to skin distance less than 10 centimeter with the favorable anatomy, then lithotripsy is preferred. If more than 100 ounce per unit, skin to skin distance more than 10 centimeter, then ureteroscopy means RIRS or ureteroscopy. 1 to 2 centimeter, if PCNL is contraindicated, then ureteroscopy. If not contraindicated, then PCNL. More than 2 centimeter, straightforward PCNL. Now on to the complication. A complication in the management of kidney stone is due to the stone, due to the procedure, or both. As we discussed in the starting, the complication are due to the kidney stone is up to the 10% of the patient suffer some type of complication due to the procedure or due to the stone. First is the due to the stone. In the due to the stone, anuria, when bilateral stone disease is present, patient present with the anuria. Pyonephrosis means first formation in the pelvic calyceal system. Septicemia, pyonephrosis lead to the septicemia. Patient having the severe hematuria or the intractable pain, it is due to the stone. Due to the procedure, first lithotripsy. As we know, generally, lithotripsy is well protected and there is no need of admission in the lithotripsy. I want to share that contraindications are also available for lithotripsy like pregnancy, uncorrected coagulopathy, untreated UTI, arterial aneurysm near stone, obstruction of urinary stone distal to the stone, or inability to the target stone due to the skeletal malformation. And some factor negatively affecting the shockwave lithotripsy is the stone composition, like the bruising that are the stone. It is not well segmented by the lithotripsy. Skin to stone disease more than 10 centimeter means the morbid obese patient, poor result. Renal anatomical anomaly like horseshoe kidney, calyceal diverticum, poor result. Unfavorable lower pole anatomy like the narrow infundibular or the lower pole calyx having the poor result. Now, lithotripsy having just some reversible and the irreversible injury, like the reversible injury that are reversible within 4 to 6 weeks, like the mild tubular necrosis, cast and red blood cell in the tubular lumen, vascular changes of the tubular lumen. It is a mild type. When we are using the high energy or multiple session of lithotripsy, it can result into the irreversible, like disruption of nephron or large hematoma, cortex and medulla, and many things. PCNL is a safe procedure in the safe hand for the experienced surgeon. But according to literature, the major complications are the 7%, minor complications occur in 25% of patients, and even the mortality is also reported 0.03 to 0.8%. The first and foremost complication is the hemorrhage. It is most common. Transfusion required in 1 to 10% of patients, and the most nightmare for the PCN and for the urologist is the formation of pseudoaneurysm and the AV vessel. In this hemorrhage, there is delayed bleeding after 7 to 10 days after surgery, and patients bleed profusely. Sometimes it resolves spontaneously, but patient may need angiography or angioembolization in 1% of cases. Sepsis means fever is nearly 25% of patients show sepsis. Need of open surgery is rare, but sometimes patient need open surgery. Adjacent organ injury like colon or spleen are rare, but if it occurs, it can managed by judiciously. In supracostal puncture means the puncture made above the 12th rib. It is chances of pneumothorax, means air in the thoracic cavity, or hydrothorax, fluid in the thoracic cavity, or the hemothorax. Pneumothorax up to 10%, or hydro or the hemothorax up to 5% of patients. Treatment is either aspiration, ultrasound guided, or the ICD. ICD means intercostal drainage. This is the radiograph of pneumothorax, right-sided pneumothorax. This is the hydrothorax, right-sided hydrothorax. Now, few words about the management of bleeding. As we know, the most of source of hemorrhage is the venous, and placement of tube is usually sufficient, and bleeding stop normally 10 to 15. But if bleeding is persist, then clamping the tube for a time may lead to the tamponade of the bleeding point, and normally the bleeding stops. But sometimes bleeding still not stop, then we can put a Foley's type catheter and inflate the balloon. That leads to the tamponade effect and control the bleeding. But if all these measures are not working, then angiography is needed, and sometimes angioembolization is needed. Or when there is no availability of angiography facility or angioembolization, then we have to open it, or the partial or the total nephrectomy is required. RIRS or the URS. Due to the presence of better optics, visualization, and small size scope availability, complications are rare in the RIRS or the URS. Overall rate is only 3.5%, and the most common is the 1.8% of patients complaining of fever post-operatively. Other complications are ureteral perforation. This incidence 1 to 4% of total patients. Causes are over dilatation of the ureter, forceful placement of ureteral axis teeth, or a traumatic injury from the forceful and the misdirected manipulation of stone. How we manage it? Ureteroscopic procedure should be terminated, and we put a DJ stent. If severe extravasation or unable to stand, then we have to put percutaneous nephrostomy, and along with supportive treatment like the broad spectrum antibiotic. Other complications are ureteral stricture, showing lower incidence due to available of the small size scope. We have the smallest size of scope is the 4th French only. Predisposing factor are the infected stone, ureteral perforation, or previous history of ureteric surgery, or the pelvic radiation. Precaution is only and only the gentle insertion of the ureteroscope. Treatment depend on the site length, time, and the nature of trauma. In few patients, only dilatation with DJ stent is sufficient, but in few patients, ureterostomy, ureteroneocystostomy, or the ureteropylostomy is needed. If the kidney is not functioning, then sometimes it leads to the nephrectomy also. Emulsion, it is the most catastrophic, but luckily rare. Incidence is less than 0.5%. Causes are the forceful manipulation of a large or infected stone, especially in the upper ureter, because upper ureter having the low muscular support. Scabbard effect. Scabbard effect means at a time of scope withdrawal, if a large ureteroscope is forcibly advanced and we remove it, then it is called a scabbard effect. It is the whole of the ureter over the ureteroscope. As you see, it is a very poor prognosis. So, how do we prevent this avulsion? Precaution, always need to precaution that this is the nightmare for the urologist and management. Avoid blind basketing. means the removal of ureteric calculus without the aid of endoscopy should not be advocated in a day. Always place safety in the working guide wire. Always remove the stone or fragment under vision. Don't push it. Don't try to remove it forcefully. Treatment. We put the piece in immediately. Then a definitive treatment according to the site and what amount of length of ureter is remain. If extensive injury, then ileal ureter or the renal outward transplant is the only answer. While in the lower ureteric injury, we can swash it or the body flap and rarely infection is needed. Other complication in the URS is the submucosal and the low stone. Submucosal is the when the iatrogenic displacement of the stone occur in the ureter part. If the stone migrated into but with the help of laser, we can remove the stone and put a stent. Low stone, when there is ureteral perforation and we push the stone into the outside the system, it is called the low stone. If the fragment is completely outside the collecting system, it can be left in place. Attempt to retrieve the stone may exacerbate the injury and increase the risk of significant irrigant excavation. So treatment is terminate the procedure and DJ stent placement. To prevent the infection, broad spectrum antibiotic is started, and we explain the patient and attendant about the stone that it is lost. Now few word how to prevent the recurrence of the stone. It is we should drink plenty of fluid, maintain urine output at least 1.5 to 2 liters per day, low sodium intake, low protein intake. Specific approach like in the calcium oxalate, we can start thiazide diuretic, cellulose phosphate as a chelator, potassium cyclate to alkaline the urine and reduce the daily sodium intake. Struvite, as we all know, it mainly occurs in the UTI with the urease producing bacteria. So antimicrobial, acetohydroxamic acid, surgical intervention and measure to acidify the urine. Calcium phosphate, it is commonly made with the oxalate and the struvite, so we treat the underlying. Uric acid predominantly occurs with the gout and the acidic urine. So we should reduce urinary concentration of uric acid, alkaline urine with the potassium citrate, use allopurinol or the febuxate, and the reduce the dietary urines. Cystine, it is common with the genetic autorecessive defect, and the treatment is the increased hydration, chelation of cystine like the alpha penicillamine. Okay, and prevent the use of potassium citrate to the alkaline the urine. Now, a few words about the Himalaya Cystone code. It found helpful in the treatment of expulsive therapy as well as to prevent the recurrence. So it is anti-lithiatic, lithotripstic, diuretic activity, anti-inflammatory, and the antispasmodic. So it prevents the recurrence, and if it is a small stone form, it can help into the removal of the stone. It is a graph showing the decrease of the colicky pain after treatment, dysuria, pain or micturition is definitely decreased after the use of Cystone port. So Cystone port is safe and effective in the treatment of urolithiasis with significant improvement in the clinical system. Helpful of the clearance of calculi, symptomatic relief, and increased urine volume. So over to Dr. Abhishek for the question answer. Then we discuss take home message. Sorry.
Thank you so much, sir. Please, sir, stop sharing. Stop sharing your screen.
1 minute.
Yeah.
stop sharing.
Yeah. So thank you so much, sir, for this enlightening lecture that you have delivered today. It was indeed a feast of knowledge for all of us. I'm sure that all the doctors have enjoyed this session and eager to. Yeah. Yeah. So I request every doctor to put your questions or queries in the chat box. We will discuss very soon. As you all know, doctors, that this online talk is brought to you by the Himalaya Wellness Company, the makers of Cystone Fort, an exclusive formulation for the management of renal stone. Before coming to the question and answer session, let me invite my colleague, Dr. Vaishali Rawat, Manager Scientific Services based at Lucknow from Himalaya Wellness Company. Dr. Vaishali, please highlight about Cystone Fort, have a brief presentation about our brand Cystone Fort. Over to you, Doctor.
Thank you, Dr. Abhishek sir, for the kind introduction and opportunity. Dear doctors, greetings from Himalaya Wellness Company. We at Himalaya are serving the humanity for more than 90 years now, and we have had this vision of wellness in every home and happiness in every heart since. So, on the occasion of World Kidney Day, Himalaya Wellness Company presented to you the online talk by Dr. Abhishek Jain. And continuing the discussion, I would like to present how Himalaya Wellness Company is being the pioneer in the management of urolithiasis through plant-based medicine. As you can see, doctors, here on the screen, that we have a lot of stone sculptures across the globe that gives us a sense of happiness each and every time we see it. They provide us a visual treat and make us feel good. While on the other hand, as you can see, there are certain stones that are capable enough to ruin all the happiness and wellness out there. And they can make one's life horrible, causing intense pain as well as discomfort. These are also known as renal calculi or urolithiasis. So here today, we are going to have a short discussion on the role of plant-based medicine in urolithiasis. We from Himalaya Wellness Company started this journey by launching Cystone in 1943 and Cystone in 2008. We continued our quest to provide the effective solution. So here we came up with another product with a holistic approach to manage urolithiasis, Cystone Fort, that expels kidney stones and prevents recurrence. Cystone Fort contains extracts of extensively researched and time-tested botanicals. Moreover, Cystone Fort offers holistic approach for the management of urolithiasis by offering antilithiatic, lithotriptic, anti-inflammatory, as well as diuretic properties. In Cystone Fort, we have Sheila Push, Didymocarpus pedicellate, providing antilithiatic action by preventing deposition, accumulation, as well as supersaturation of the stones. Also, Manjishtha, Rubia cardifolia, hydroalcoholic extract of which have antilithiatic action, which decreases the levels of calcium, oxalate, phosphate levels in urine and also helps in dissolving the oxalate stones. The extracts of Pashanbhed, Saxifraga ligulata, if I talk about, it has an inhibitory effect and also dissolves the mucin, which binds these stone particles together. And an anti-inflammatory action is showcased by Nagarmusta as well as Bantulsi, Cyprus scariosus, and Osmum sanctum. And diuretic action is also shown by Apamar Acaranthus aspera as well as Gokshur, Tribulus terrestris. So If we talk about the mode of action of cystone 4, then it prevents throughout the stone formation, it prevents the crystal growth by correcting the crystalloid-colloid imbalance and renormalizes the urine pH. It also prevents the crystal retention and crystal tissue interaction by soothing the inflamed tissue and prevents the implantation. It also dissolves mucin, which binds the stone particles together and flushes the stones by promoting diuresis and therefore preventing stone assembly. There have been many studies regarding cystone in national as well as international papers. So here is presenting to you this one important study published in the Journal of Urology and Research, showcasing the safety as well as efficacy of cystone 4 in the management of urolithiasis. As you can see here, conclusion in the study, it shows 53.3% of complete expulsion of your kidney stones in the calculi size of 7 to 12 mm, while other patients also showed significant improvement. And in case of calculi size 5 to 6.9 mm, 57.1% complete expulsion of kidney stones, while other patients also showed significant results. Moreover, clinical parameters like colicky pain, abdominal pain, dysuria, pain on micturition showed great improvement. And hematuria, nausea, vomiting, fever with chills, etc. were also reduced significantly. So we concluded that cystone 4 is very safe as well as effective in the treatment of urolithiasis, but it also provides significant improvement in clinical symptoms. Moreover, it does not have any adverse effects that have been observed or reported. Another study in which safety as well as efficacy of cystone 4 was compared with tamsulosin. This study was published in Medical and Surgical Urology. The study concluded that cystone 4 is having comparable results with improvement of clinical parameters in urolithiasis and expulsion of kidney stones as compared to tamsulosin group. Yes, it has additional benefits also like anti-lethatic activity, lithotriptic activity, anti-inflammatory properties, along with the diuretic properties. So the indications of cystone 4 is in urolithiasis, stones up to 12 mm, and crystalluria, and also it helps in managing the post-lithotripsy complications. The dosage of cystone 4 in urolithiasis, urinary stones up to 12 mm, and crystalluria in adults and children above 12 years of age is 2 tablets twice daily till the stone passes out or till the symptoms subside. And also in post-lithotripsy urolithiasis, 2 tablets twice daily for a period of 6 weeks. I would like to conclude my presentation with saying that cystone 4 helps in kidney stones as well as preventing the recurrence of the urolithiasis. So thank you so much for listening to me. Thank you again. Over to you, Dr. Abhishek Boss.
Yeah, thank you, Dr. Vaishali. Please stop sharing. So thank you so much, Dr. Vaishali, for highlighting about various ingredients of cystone 4 and indication and various action that we are providing with this formulation and various studies that you have highlighted. Thank you so much. Now the session is open for question and answers. Before that, I am glad to highlight that more than 700 doctors have logged in and many more are logging in. Now, the session is open for question and answers. We have received many questions. Abhishek Jain sir, I would highlight few of them. Can you hear me, sir?
Yes, I am hearing.
Yeah, sir. So, sir, what complication will happen in 8-month pregnancy if she is diagnosed with CRF? You were highlighting some factors that affects management. So, what complication will happen in a pregnant lady?
Dr.
of 8 months?
Abhishek, it's depend if the maternal health is no good, then the fetal health is also affected by the maternal health. If patient is diagnosed with the acute renal failure, then the management is different, and if it's patient of CRF is pregnancy, the management is different. If patient of renal failure ARF due to the obstructive uropathy, we want to put the either the DJ stent or the PCN as much as time when the delivery is done. After the delivery, we give the definitive treatment. If patient of CRF presented with pregnancy, then treatment we will search out the cause for the renal failure and depend according to the etiology, we will do accordingly, and we also take the opinion of gynecologist for the fetal well-being.
Yeah, thank you, sir. Another one, sir. Please suggest about the preventive aspect of renal calculi, specifically in case of diabetic patient. How we can increase a life of kidney in a diabetic patient?
First and foremost is the complete control of the diabetes. If we control our HbA1c, blood sugar, fasting keep in the normal rate, then very less progression of kidney diseases or very less of the diabetes on the kidney. And we also check on the hypertension because it is commonly seen in the metabolic syndrome, patient having diabetes, obesity, and the hypertension. So first and foremost thing is the maintenance of weight, hypertension, and the diabetes. If we control all these things, we can put our kidney in a good shape.
Yeah, thank you once again, sir. Another one, sir. What treatment option we have in pediatric age group when renal stones are seen accidentally and patient is having no pain or no symptom?
Again, we have to investigate the patient fully, radiologically as well as the metabolically, because in the pediatric age group, it is assumed that it is due to the metabolic disorder that can lead to the stone formation. First, the treatment of the existing stone by the radiological diagnosis. If there is no hydronephrosis, then we can wait and watch observation. But if it is hydronephrotic or more than 5 or 6 mm of the stone in the pediatric age group, in my opinion, it should be reported by the PCNL, RIRS, or whatever modality is required.
Yes, sir. So another interesting one, sir, you were highlighting about this in your slide. Geographic condition plays an important role in the formation of renal stone.
Yes.
Yes, and if we look at the regions like Eastern UP, Bihar, and Jharkhand, prevalence of stone is high. There are certain geographical conditions you were highlighting. At the same time, if we look at the veg and non-veg population that we have in this particular area, it also directly affects the recurrence or prevalence of renal stone. So please highlight how we can avoid prevalence or recurrence of renal stone in these particular states that we have.
Some factor that we can manage is like increase hydration, decrease sodium intake, decrease in the animal protein intake, or we should watch for the urine output. If it is dark color, then this means the urine is concentrated, and we can take 12 alkylinizer like the Cystone, Renalca, or other available medicine in the market. First, and I want to tell all the listeners that you should maintain the hydration. If you are maintain the hydration, then there is very less chance of stone formation, and if it may, it will remove spontaneously.
Yeah, thank you so much, sir. Last one, sir. In Indian scenario where we know that most of the Indian population live below poverty line, or we can say they do not have adequate nutrition. So is there any link between nutrition and kidney disorders, and how we can prevent all these things, especially if we talk about the renal
Yes.
stones?
Yes, as I say, the high animal protein or the less protein intake, both are not very good for the renal function. In the pediatric age group, when there is the less protein intake, it will lead to the bladder stone formation. Ammonium acidurate stone are common in the less privileged child. Those are the protein malfunction. Of the protein, having the less protein in their diet, lead to the bladder stone formation. And so we should take at least 1 gram per kg of body weight of the protein in our diet. So there is the proper formation of all other amino acid and lead to the maintenance of the body.
Yeah. Thank you so much, sir. Now, yes, sir, please.
No.
Yeah. Okay.
I will give you a take-home message.
Yes, sure, sir. Yeah.
Okay.
Yeah.
Yes. Message.
Sir, your voice is not coming.
Okay. Now it is coming.
Yes, sir, it is coming, and slide is also visible.
Chalo. Okay. Urolithiasis is a common disease. Urolithiasis incidence is increasing nowadays due to our food habit and the environmental condition. Earlier diagnosis and treatment doing the complications area is easily well, easily and we
So your voice is cracking. Yeah.
I think thanks to all our I think there is some net problem here.
Stop
No
sharing,
issue, sir. Just stop sharing, sir. And yeah. So once again, thank you so much, Abhishek Jain sir, for highlighting about complication during management of kidney stone. It was a wonderful session that we all had today, and thank you so much once again. Now thank you, sir. Now let me invite Mr. Nitin Rai sir, his sales manager Zenith SBU based at Lucknow, for vote of thanks. Over to you, sir. Nitin Rai, sir.
Good evening, doctors, and good evening, all the participants. Thanks a lot for giving your valuable time for the entire session, and it was really very pleasure for me and my team, and motivation for my team the way the entire session has gone. The question and answers which were been asked, and I thanks all the participants for putting giving a motivation to all of us. Just to add on, Dr. Sabs and all my participants, Cystone is one of the unique product which we are giving to you, offering the benefit to the patient, which is been tested by more than 50 clinical trials for more than 50 years. जिसको हम लोग सिस्टोन मेटालिसिस स्टडी के नाम से आप लोग को बताते रहते हैं, and where it shows that it is a very trusted and tested brand, which is very much useful in urolithasis. We'll request all the doctors and participants to pass the advantage of Cystone Fort to the patients wherever you get opportunity, and add more confidence to us for taking this product forward. Thanks a lot for giving a valuable time. And once again, I'll request before signing off, wherever you get a chance, Dr. Saab, pass the advantage of Cystone Fort to your patient. Thank you.
Thank you so much, sir. At last, from the team Himalaya, I am sincerely thankful to Dr. Abhishek Jain sir for today's session. On the behalf of Team Scientific Services, I am thankful to all the colleagues of Himalaya Wellness, those who have joined hands together to make this event today. So thank you so much. Thanks a lot. Jai Hind. Mr. Nishad, is it offline now?
Yes, sir, it's offline. Can I end the meeting?
Yes, sure, sir.
Okay. Thank you.
Thank you so much, sir. Thank you so much, sir.
Thank you. Thank you each and everyone, Praveen Kore sir, Nitin Rai sir, and all the event management team for making it happening today. Thank you so much. Thanks a lot.
Thank you, everyone. Have a great evening and a great Sunday.